he was going to join, and our law enforcement leadership and our coalition members. I really appreciate you being here today. It's an honor and a privilege for me to get to introduce Dr. Libby Stout. Dr. Stout is an addiction psychiatrist, researcher, and presenter on the health impacts and societal costs of cannabis legalization. Dr. Stout has published extensively on addiction and other neuroscience topics for over 45 years. She was the medical director of the Circle program, an inpatient treatment program for substance abuse and mental health treatment at the Colorado State Hospital in Pueblo, Colorado from 1999 to 2018. Dr. Stout currently dedicates her time and energies to educating medical providers and the general public on the science and impacts of cannabis, particularly on the impact of high potency THC on the developing adolescent brain. So very grateful to have you here. I'm turning it right over to you, Libby.
Okay, thank you very much. I'm very happy to be here and share with you our experience in Colorado. I have a little slideshow that I'm showing. So let's see if we can get it to go. All right. So, and you can stop me anytime and ask questions. I can't see the chat right now, so you'd have to like say something, but I will stop and ask. Commercialization, which is really what's happened in Colorado, has really changed marijuana. So if you think about the old time marijuana, back when we legalized medical, like you're thinking about, that was in 2000. The highest potency in the plant was 4 to 5% THC, and we didn't have any concentrates at that time. And I think people were voting on the fact that, well, maybe this will help those poor people that are dying of cancer. Today we have, with no regulations really, we have very extreme products that push the THC up massively, and people are smoking it with a blowtorch. So this is what's happened in Colorado. We, you know, marijuana has been around for centuries, and always up to the 1980s, the THC content was less than 2 to 3%. So that's the old time marijuana that some of you may have indulged in. But what we have now is totally different. We now have an average of 20% in the plant. And some plants, they brag, are up to 30, 40% THC. And then we have these concentrates that are well up to 90%. Some even say 99.9% pure THC. And we don't really have any research on this at all that says it's medical, but it's still used as medicine. I really like this graph because it explains things perfectly. You know, when you have prohibition, you do have problems. You have a very unregulated illegal market, and that creates problems. However, decriminalization is what I support. You lessen the problems a lot. If you decide to legalize, you really have to have very strict regulations. However, with what we have in Colorado right now, we basically have an unregulated legal market. So that's why we are seeing so many harms to individual and society. Medical marijuana is a Trojan horse. I want you to understand that. Every state starts with medical, and they say they're not going to go recreational. I've been working with the people in South Carolina who are trying to fight the bill that is currently in their legislature. And I heard Senator Davis talk at the Cannabis conference that was at the Medical University of South Carolina last Friday. And he was adamant that his bill was going to be the best bill in the country because it was going to be the best medical marijuana known to man. And it's not going to result in adult use or legal use for adults recreationally, because that's not what South Carolinians want. And he gave this quote of 71% of South Carolinians don't want adult use. Later in that same conference, there was a physician from Colorado, Dr. Adnoff, who actually gave the opposite result, saying that 71% of South Carolinians want adult use. And so this is really a slippery slope. In the conference, when Senator Davis was talking, he talked about how he had the biggest opposition from law enforcement because they did think this was a slippery slope. And he was slowly working with them to try and get them to allow smoked cannabis. Right now, the only thing they have is allowed is oil, which still can be vaped. But I just do want to point out, we do already have cannabis-based medication. We have it that's gone through the FDA approval, and it's available and it can be used. Physicians can prescribe it all the time if they so desire. The only one we don't have here yet is Sativex. It is currently going through FDA approval for this country, but right now it's available in almost all countries. It's a natural product that's a balance of THC and CBD, but very low dose, 2.7 milligrams of THC in a spray. It's an oral mucosal spray. And so we have these things available. Medical cannabis is the plant and the plant material, and then the extracted, the things that use butane to extract. And this really ends up being poorly regulated and poorly tested for contaminants. If you look at the research supporting medical cannabis, it is out there. There is research. However, the National Academies of Science, which came out in 2017 and talked about all the things that cannabis might benefit, they used this review article for most of the studies. So this is a very large systematic review and meta-analysis of all the studies. Most all of these studies were done with those prescription drugs I just talked about, like Sativex. There were 2 studies looking at smoked cannabis, like what's available in dispensaries. And the benefit was in stuff less than 10% THC. That's very important to recognize. There's no legitimate science at all that exists to validate medicinal cannabis greater than 10%. In fact, there was this very interesting study that they did just to see, well, does it actually really work for pain, period? So they got healthy volunteers being willing to be injected in their forearm. Like, you get a TB test. They injected capsaicin, which is the stuff out of hot peppers. And apparently that causes a lot of pain. And they found that when people had that happen to them, if they smoked 2% THC, there was no pain benefit. If they smoked 4% THC, there was actually some pain decrease, so it helped. 8% caused increased pain or hyperalgesia. So you're getting into the fact that higher doses are not really effective. And we see that also with opiates. That's why opiates are not really good for long-term chronic pain. This is a chronic pain researcher who has done a lot of work, and he has come out saying that what is tolerable and effective for pain management in terms of cannabis is less than 10%. This stuff that goes up to 12% is in people that might be already tolerant to marijuana, so they've been using it regularly and they tolerate the side effects. So it might be helpful up to that level in those people. But these people, this is really more recreational use. And so anything higher than 10% is really considered recreational. So if you're considering medical marijuana, it shouldn't be higher than 10% THC. However, in Colorado, that really isn't available. So this same researcher that I just showed that slide, his group went around the country to the different states that have legalized medical and recreational and looked in the dispensaries to see what was available. And this is what they found in Colorado. So in Colorado, in medical, almost 90% is higher than 15% THC. So this stuff that is supposed to be helpful for you is really not available. And so most people are, and concentrates make a large part of this. So it's almost 50%, but 40-something% of this is concentrates. So those are the much higher potency THC plants, products. We did have a bill in Colorado that we had to push, and it passed unanimously, basically bipartisan, in both House and the Senate. And I'll talk a little bit more about that later. But this was actually to try and bring down some of this really craziness. Prior to our bill passing last session, and it started this year, somebody with a medical card could buy 40 grams of product every day versus 20 in the retail market. And of course, the taxes are lower in medical, but there's no medical marijuana recommendation or specification or monitoring for looping. So that meant people could go from one dispensary to another dispensary to another dispensary and still get more and more product, which is crazy. So these are all things that you have to think about when you're really looking at doing this. This is a fascinating article, and I really encourage everybody to read it. He's done an excellent job. I'll share these slides with you so you can click on this. This is a link that goes to his paper. But this is Dr. Messamore. He's a psychiatrist. And he talks about how marijuana has been around forever in the pharmacopoeia. So we've been using it as medicine forever. But before it became a political issue and something about, profit motive, because this truly is an industry based on profiting from addiction. He said that physicians would use it. It was in their pharmacopoeia, but they knew that there were side effects and they warned everybody about the side effects. What we have right now, especially in Colorado, is we have a medical market where nobody knows there's any problems with it. It's been allowed to be heavily marketed and advertised as medicine. So everybody thinks it's safe, that there's nothing wrong with it. But these are some quotes I got out of his paper just from all these textbooks that were back there. Like this one in the bottom in 1895. Sometimes the delirium induced by hemp causes the individual to do deeds of violence, but does not act upon all alike. Those after effects are those of depression. And then the most common effect, however, is the development of insanities, which we have known for many years. In large doses, it will produce hallucinations, which are some of the merriment and also are of a violent nature and a tendency to crime. The habitual use will cause insanity. So these are doctors saying, yes, this may have medical benefit, maybe, but it also has a lot of downsides. So I'm going to talk about the downsides. The stuff we have been seeing in Colorado that are very significant because of this. First, I'll talk about addiction. We know that when you increase the potency of any drug, you increase its addictive potential. We know this for all drugs. And so what we now see this is for marijuana. In the olden time marijuana, we didn't used to think this was addictive. But now with the stuff higher than 15%, we are definitely seeing true addiction to this, what is now called cannabis use disorder. And the Dutch figured this out. They noticed that when their potency in their plant got to 20%, which is what ours is average in Colorado, there was a lag time, but there was an increased need for admissions for treatment for cannabis use disorder, pretty significant. They actually came out in 2016 and said they believe that anything above 15% should be considered a hard drug like cocaine. And they actually capped the potency at 15%. With that, then there became a decrease in the need for admissions for cannabis use disorder. It's still, significantly a problem. And this is the withdrawal syndrome. So many people say, oh, cannabis isn't addicting. And I just tell them, well, stop using and see what happens. Because if you've been using regularly, you're going to have withdrawal syndromes. And they can be very uncomfortable, which then causes people to have to keep using. So it makes it very difficult to quit. So this is very similar to like nicotine withdrawal. Nicotine, many people say that's the hardest drug to quit. Well, I am now seeing in my practice that marijuana, the high potency stuff, is very similar to nicotine in the fact that it's almost impossible to quit. And so these are the things that people look forward to when they become physiologically dependent on marijuana. And this happens with medical marijuana. And of course, it makes sense that it does, because when people are using medicine, they use it every day, sometimes multiple times a day, right? So if you're using a high potency product multiple times a day, then you are addicted to it. Now, I've had many people in the industry tell me, oh, they don't meet criteria for cannabis use disorder. They haven't had any problems because of their use. It's just benefiting them. And I said, well, wait a minute. They may not have cannabis use disorder, but they are physiologically addicted to it. And if they stop, they have withdrawal, which means they have to keep using. And this is why then they think that they need it, because withdrawal is the exact opposite of what a drug does for you. So if a drug helps with pain, withdrawal is painful. And so these are things that, this is just a very interesting study looking at people that you're using medicinal cannabis, and the fact that 25% of them actually have severe withdrawal. And so basically they're looking at, they're having sleep difficulties, depressed mood, decreased appetite, cannabis cravings, restlessness, irritability when they don't get cannabis. And what they found is it's associated mostly with smoking cannabis, more so than edibles. And the longer they've been using and the greater frequency of use is going to cause more withdrawal symptoms. Then we get into the mental health problems. This is the most severe problems. And so this is the one that really got our legislature to look at this seriously, because we had so many family members and patients testifying in front of the legislature with their psychotic symptoms. So this is one of the landmark studies that first came out. This is looking at people with first episode psychosis and their use of the higher potency marijuana, which in the UK they call skunk. And so this is stuff that's 15% or more. If they were using it, they had a 3 times increased risk of psychosis. If they were using it daily, they had a 5 times increased risk of psychosis. And if they were using the stuff that was 5%, like what we had when we first legalized medical in 2000, there was no associated risk for psychosis. You're not going to have that benefit. There isn't 5% anymore. You are already in this realm of the high potency products. And so you're going to see increased problems with psychosis. This study was then expanded multi-site around Europe, and they found similar results for 10% or higher. So it's not just 15% is the cutoff, it should be 10%. And of course, that's what we have research-wise for medical. Anything less than 10% might be helpful, but anything higher than 10%, it puts you at significant risk for psychosis. And just to make sure everybody knows what psychosis is, psychosis is when somebody has an altered state of reality. They don't feel like things are real. They can see things that nobody else sees, like they have visual hallucinations, they can have auditory hallucinations, they hear people talking to them that are not there. They have delusions that can be very fixed, like they think the CIA has implanted electrodes into their brain and they're monitoring them, or somebody's, poisoned their food so they can't eat. There's all kinds of things going on, and they become extremely paranoid. So that's what psychosis is. And this is just showing, in the Netherlands, it was the worst. So in Amsterdam, it's hard to see this, but I'm just showing that this is high potency, which is greater than 10%, used more than once a week. This is lower potency, used more than once a week, so it has less risk of psychosis. And this is high potency, greater than 10%, used daily, has the most significant increased risk of psychosis. And they really do think that if they did not have the products that were 15% or 10% or higher, they could have avoided 50% of these cases of psychosis in the Netherlands. And this is happening in Canada too, where, and I think it's important to recognize this research is done before they legalized adult use. So this was purely based on their medicinal cannabis legalization. And this was showing that between 2006 and 2015, because they didn't legalize adult use or recreational use until 2018. So this is just with their medical marijuana. The hospitalizations during this time period increased significantly, especially with the code for psychotic disorder related to cannabis. It tripled. And so this is kind of what you're looking forward to in your mental health system, in your hospitalization system. And this is a study out of Denmark, just showing that, yes, many drugs cause psychosis. Even alcohol can cause psychosis if somebody's really acutely intoxicated and they have alcoholic hallucinosis, or if they're in delirium tremens when they're in withdrawal, they can have psychotic symptoms, but that is extreme. Here we're talking about just using a substance. It can be one time. I've seen many people that have had psychotic symptoms with their first use, and they do not have to have a history of mental illness or symptoms, and they don't have to have a family history of mental illness or symptoms. And this is just showing that the drug that causes the highest conversion rate to either bipolar disorder or schizophrenia was cannabis. That's different from methamphetamine, cocaine, opiates. So cannabis, and especially this high potency stuff, has the highest risk for this. And then this is again from Canada, Ontario, looking at their hospitalizations for all reasons. And this is before they legalized recreational. So this is just with medical. And the more years that medical was available, the more hospitalizations there were. And so this is in men, it's across all age groups. Red is 2003, blue is 2008, orange is 2013, and green is 2017. So the longer they've had marijuana available, the more hospitalizations they had that marijuana was causing possible harms. And the same happened in women, but it was seemed to more focused around the age group of 15 to 19. And then also the sad thing is what happens with the children, the little kids who get a hold of the gummies or the brownies or the cookies that look just like normal candy and cookies when they're outside the packaging. Yes, there's rules about packaging and how it has to be child-proof and child-resistant, but once they're opened, they look the same. And so if there's a gummy on the table, a child doesn't know that that's a cannabis gummy. And so in what they've seen in Canada, and again, this is before recreational, but it's significantly increased since they did recreational. They've had this 800% increase in cannabis poisonings in these kids. I heard this guy, Dr. Adenoff from Colorado, talk in this Medical University of South Carolina conference, and he, to me, greatly minimized this. He said in Colorado, we've had like 202 kids in the hospital because of poisoning by cannabis, but they didn't die. I mean, that is to me awful to say, because yes, they didn't die. I'm glad they didn't die, But it's very distressing to a family when your child is obtunded, can't be awakened, and you don't know what's wrong with them. And sometimes they have to be in the ICU for a couple of days trying to get it out of their system where they can wake up again. This is what we're seeing in Colorado. This is a little old because it only goes up to 2015, but you definitely can see the trend. These are adolescents coming to emergency rooms or urgent care centers in Colorado, and it continues to increase. The very concerning one is this need for behavioral health evaluations. So these are the kids that are coming in with psychotic symptoms, suicidal ideation, anxiety attacks, depression, that are definitely related to cannabis. Then we have this relationship with suicide. You know, as everybody always wants to say, correlation does not mean causation, and that's very true, but that's why we do research. You're trying to find out if there's causation. And I think we're having more and more data to support the idea that marijuana might cause suicidal ideation and thoughts. And if you think about the way marijuana works in the brain in terms of the endocannabinoid system, that may be why, because that is our balancing system, our homeostatic system, that is our mood regulation system. And cannabis can definitely interrupt that. And then it also can affect your prefrontal motor cortex, which is where you make your decisions, your executive functioning. So if somebody's mood is dysregulated, they're very unhappy, and then they think, oh, well, I could just kill myself, and they don't have the ability to stop because of executive functioning not working, that may be why we see that increased risk, but we don't know. But this is just looking at over 23,000 adolescents and comparing those who use marijuana to those who don't. And the odds ratio for suicide attempt is very significantly high. And in Colorado, we're seeing this, that the #1 drug present in toxicology by teens who die by suicide is marijuana. And that far surpasses alcohol, which used to be the major drug, but now it's marijuana. And this company came in and said that the Colorado teen suicide rate increased 58% from 2016 to 2019, which is the highest increase in the country. If you look at CDPHE data over the last 5 years since we legalized recreational, there has been a significant increase in the number of teens who have died by suicide. We also noticed that they weren't getting toxicology all the time anymore. So that's something we addressed in this bill so that we can be sure that they always check for toxicology. That's something you should write in your statute that you need to be following this and collecting data, because still, even though we don't have toxicology on everybody, and the ones that we do have, marijuana is the primary drug present. Also in veterans, this is a very large study looking at over 3,000 veterans and comparing those with cannabis use disorder to those who don't have cannabis use disorder and their suicidal ideation and suicide lifetime attempts. This is an excellent study because they controlled for pretty much everything that can contribute to suicidal ideation, and they found that cannabis significantly increases the risk for suicide. Brain development is extremely important. Your brain is constantly.
So this is Representative Albert Summers. Could you go back to the last slide?
Yeah, sure.
So that's a very interesting slide. So kind of talk a little bit more about that and whether, you know, if you, obviously there could be a correlation between those that have a tendency to want to use the drug with those that want to, those that are inclined for suicide. So there could be, it's not necessarily a cause and effect. It could also be the same people are prone to the same thing rather than one's the cause of the other, if you see what I mean. So talk to me a little bit about that. And just in general, I don't support marijuana laws, and
Okay.
I don't want to legalize marijuana.
Okay. Well, no, I actually have a couple slides after this, but I will talk about that. Yes, many states have legalized or put PTSD as a condition for medical marijuana, and that includes Colorado. And I think that's absolutely wrong because of a lot of studies that have been shown. Cannabis, yes, of course, it works for symptoms of post-traumatic stress disorder, just like alcohol works, just like benzos work. Any addictive substance that numbs you can take away those symptoms of trauma, like startle reflex or flashbacks. But in order to keep those symptoms at bay, you have to use every day, and you have to use sometimes multiple times a day, which sets you up for addiction. So it sets you up for cannabis use disorder. And it also sets you up for psychosis, worsening psychosis from post-traumatic stress disorder, because that can also cause psychotic symptoms. And so that is why I think this really does speak more to causation in the fact that it's cannabis use disorder. It's not just using it occasionally, it's using it regularly to the point where you can't live without it. And that has been shown in multiple studies. There hasn't been any study to date that shows that cannabis really treats PTSD. And we have lots of really effective treatments for post-traumatic stress disorder. In fact, most of them cannot be done in someone who's under the influence of anything, like EMDR. So that's why this is a problem. Does that answer your question?
Yeah, yes, kind of. And maybe if I looked at it harder, I just think that there are reasons people do certain things that, you know, they could be prone to using that substance, right? Their minds could crave that. And they could also be prone to suicide. So teasing out cause and effect is sometimes difficult when if you see what I mean.
Yeah, I mean, except that's why I think the fact that they controlled for all these things that can contribute, because there's a lot of research out there that says just having PTSD increases your risk of suicide. Gender, there's men are more likely to complete suicide. Women are more likely just to attempt it. So there's a lot of things out there like history of childhood abuse, higher ACEs scores are linked to suicidal ideation, suicide attempt, and then combat exposure. And so that's why the fact that they controlled for all these things that also contribute, I think, is stronger that cannabis actually plays a role in that. And just in terms of development, your brain is not developed until mid-20s. Our brain is constantly developing. And so one of the best things that has come out of all this cannabis research is a better understanding of the endocannabinoid system in the brain and what an important role that plays in brain development. And so this is just an excellent article if somebody wants to get that and read it, because it really talks a lot about the endocannabinoid receptors that we have, because we have chemicals in our brain that we create to put in those receptors. It just so happens that THC fits in those receptors. That's why they were called cannabis receptors initially. It's very sad they were ever called that, because that made people think that, oh, we're supposed to smoke cannabis. We have these cannabis receptors in our brain, but that's not why we have them. Therefore, our own natural chemicals, named anandamide, 2-AG. But anyway, during development, in utero, the brain is definitely developing, and then infancy and childhood is massively developing brain. And during adolescence, a very important thing is happening because the brain is deciding what are we keeping and what are we getting rid of. And we're going to strengthen the ones we're keeping and we're myelinate those nerves, and then we'll prune some other nerves. And the endocannabinoid receptors play a big role in that. And if you put THC in a developing brain, then you totally disrupt what's happening, and you have no idea what you're doing because you're not allowing the brain to prune appropriately. And then in adulthood, which is when, really, if people are going to use marijuana, that's when they should start using it, because there isn't much brain development during that period. So it's not really going to affect it. And that's why there's so many studies out there looking at use when someone is pregnant. This is just one of them. There are many of them. This just has a lot of children. When they were comparing those that were exposed prenatally to cannabis to those who weren't, and they found that the kids that were exposed had a greater psychopathology during middle school. And that meant that they had more problems with acting out, maybe psychotic symptoms, those kind of things. Here, this is what my answer in terms of PTSD. There have been many studies on this, and like I said, nothing is proven. But this study just looked at veterans who had been in a VA PTSD program, and they're usually inpatient about a month long. And then they followed them for 4 months afterwards, and they were looking at how they were doing compared to their use of marijuana. And those who never used marijuana had significantly lower symptom severity at 4 months, so they were doing better. The stoppers, meaning those who quit using marijuana, had the best outcome. But the ones who started using marijuana after their treatment for PTSD had the highest levels of violent behavior and PTSD symptoms. Ooh, I gotta go. And so then we also have violence associated with it. This is just following people from a psychiatric hospital who were released, and then following them different time periods, and they found that cannabis use was associated with an increased risk of subsequent violence, significantly greater than alcohol or cocaine. This is an interesting thing I just got from somebody who, this is a New York Times article back in 1970, who just said that maybe, and the link is here, you can read it. It's just, again, more support that marijuana can cause violence, like those doctors back in the 1890s knew. Then also a thing you're going to look forward to is this very weird idiosyncratic reaction to cannabis called cannabinoid hyperemesis syndrome, where people are having extreme abdominal pain, nausea, and vomiting. That's not supposed to happen, but we're finding with the higher potency products where people are using more regularly, they're having this more often. Then this has not solved our opiate epidemic at all, especially in Colorado. We have had marijuana available since 2000, and our opiate overdose and all drug overdoses have dramatically increased. So marijuana has not solved this problem at all. And in fact, the industry likes to use this first study where they said that states that have a medical cannabis law had a lower than expected opiate overdose mortality rate. That was back in 1999 to 2010. And they said, well, that's proof that expanding cannabis laws would reverse the opiate epidemic. However, this other group went in and used their exact same data, their exact same study, and they expanded it. And by that time, there were many more states that had got a medical cannabis law. So there were many more patients they could look at. And they found the exact opposite, that states with a medical cannabis law had a 22.7% increase in opiate overdose deaths compared to those states that didn't have a medical cannabis law. And this is just showing that if you're using marijuana, you're more likely to have a prescription opiate use disorder than if you were not using marijuana. So this is also great data. My experience, I don't know that I have time to get into this, but this is just in my treatment program that I ran in Colorado for 20 years. I started seeing worse and worse problems with marijuana. It used to be, it was just, something that most people did, but it wasn't a big deal. I started seeing more people with their primary drug being marijuana, as opposed to heroin, methamphetamine, alcohol. And I was seeing more significant cognitive problems, really severe delusions that I had never seen even with methamphetamine. And so this is something that got me really interested in looking into this more. So basically what we have to do about this is just educate. That's what I try and do. We need stricter regulations and we need people doing drug screens, and don't opt for the Colorado panel. When we moved my program from the state hospital into the community because the state closed the program, I was looking at companies that could do drug screens. And so this one company from Florida had 3 panels for me. One was all the drugs of abuse. One was all the drugs of abuse and all the psych meds that could be tested. And the other was all the drugs of abuse and all the psych meds that could be tested minus marijuana. And I said, what is that all about? And she said, oh, we call that the Colorado panel. We've heard from primary care doctors that they don't want to know that their patients are using marijuana because they don't know what to do about it. That's really sad. And then I find out that Denver Health has eliminated marijuana from their drug screening panel. So how do we get the data if they're not even doing that? So what our bill accomplished was several things. We're having the School of Public Health is doing this systematic review or a scoping review of research, trying to come up with what is considered a safe potency level. And they're supposed to have, they had their initial report in just recently of how far along they are, but it's just they've narrowed down over 50,000 reports to about 5,000 that they're now really reading intensively. And we're getting toxicology. The main thing we have is limits on concentrates now 2 grams per day for 18 to 20-year-olds and 8 grams for adults. That's down from 40 and 20. There's still a lot of marijuana. That is a lot of THC. And then we have a tangible educational resource requirement, meaning this is what has to be handed out to people in dispensaries. And it's 4 pages, so it's pretty long, but it had to have, what is a serving size, recommended serving size? That's this tiny little dot here. That is how much of a dab you're supposed to smoke at 1 serving. That's insane. But you're supposed to put your little piece of shatter next to it and see if that fits that. And then we have warnings. So we have warnings for psychotic symptoms, mental health symptoms, cannabis hyperemesis syndrome, and cannabis use disorder. We tried very hard to get suicide in here, but they were very resistant to that. And so this is basically the handout, and it has resources for people to call and things like that. But I will stop here because I think I've gone way too long. Oh, okay. Any questions on that?
This is Albert Summers again. First of all, I want to thank you. I'm sorry I was late. I appreciate all you've compiled. I guess the thing as a legislator is, let's say legislation eventually comes down the pike and there's support for it. And I've talked to my sheriff and my prevention specialist about this. But what are the things we should do? What are the biggest control piece we should put in there? And it looks to me like, for example, if you start with medical, you want to make sure anything you have is less than a 10% THC, right? So if you, that looks to me like the biggest takeaway of anything. And, I don't know, it's coming to every state. I hope it doesn't come to Wyoming, but I'm not naive either. So I think as a policymaker, I have to figure out how do I modify any legislation that makes most sense for people and for health. So if it's once again, I've told my prevention specialist and my sheriff, what's the short list? Give me 5 things I need to do to put in a bill in the end, if it comes, to make it to cause the least harm possible to the citizens of my state. So
Yes, you've got your work cut out for you. I'm glad you're thinking about it. I definitely believe that if you can get a limit on THC potency to less than 10%, that's a first start. You definitely need some very strict regulations about treating this like medicine. So one of the problems we've had in Colorado that we're trying to address is that, we have many medical marijuana doctors where they just have to go spend maybe 5 minutes, and during COVID it was just on Zoom, so there was no physical exam, and they would spend 5 minutes and get their card, and then the doctor doesn't tell them what to get. They go to a dispensary and get whatever they want or whatever the bud tender tells them to get, and that's not the way we do medicine. And so some states have actually required that you have a pharmacist in the dispensary or a physician in the dispensary who is educating the person and helping them determine what to use. Because there are cannabis doctors out there who are, I think, legit in the fact that they're really trying to do this appropriately with low dose of THC, low dose CBD, and actually trying to help people with minimal effects. But in my experience, they're rare. And so requiring that they have some kind of education, both on the use of marijuana, medical marijuana, and the consequences, so that they're knowledgeable about the consequences, and then that they have to tell the patient about the consequences, those kind of things. Yes, Pepper. You're muted.
Okay. I want to thank you too for doing this. And I kind of have a different question, I guess. But okay, with all of this that we're seeing, the things that are coming, what is the primary reason that anybody should even vote to legalize this? And also, are there any studies or information anywhere on how this is a revenue, a wonderful thing in revenue, and that the cost for mental health doesn't offset that? If you could just address that a little bit, I'd appreciate it.
Sure. I think that's the problem. We don't have anybody really doing those cost benefit analyses, because all people are looking about, and especially the legislature, is the dollar signs. And, oh, look, it's going to bring us so much money. And I think that's why I say medical is a Trojan horse, because really the goal is to get recreational in there. And, I think states should just bite the bullet and say, okay, because there isn't any reason to do this, since we have FDA approved medications, and we don't have data that says these are safe or effective. And that's, I mean, if you were able to limit it, so you would say no dabbing, no shatter, no wax, no vaping, so no smoking, no vaping, because we don't do those any kind of medicine. They affect the lungs, so that's not medicine. And if it was limited to the tinctures and the edibles, and it was limited to less than 10%, and people were actually following the science, that would be one thing, but that's not going to happen. It just isn't. It's like the horse is already out of the barn, and so you can't push him back in again. And it is all about money. And the industry will fight the potency cap, because that's how you addict people. The higher potency is, you're going to get more sure people to be using your product. And so they're going to fight it tooth and nail. Representative Heiner.
Thank you, Libby. This is one of the best presentations that I've ever seen on cannabis, and I appreciate the efforts you put forth to educate us and put this together. My question, Libby, is if we, for some reason, have to pass legislation and we put this potency cap on it of 10% or less, how do we keep that, keep bleed over from surrounding states coming into Wyoming? Because now we've legalized having marijuana in your possession. How do we keep this high potency from coming across the borders, or from our citizens going to Colorado, for example, and bringing some of it back and being in the same boat that our surrounding states are in?
You're absolutely right. I don't think you can. And people are already coming here. You know, our first death was a student from Wyoming who jumped to his death after a psychotic episode. It was back in 2014. So yeah, I don't know. I don't think you can prevent that. And that's why the biggest piece has to be prevention, has to be education, and we have to be making the doctors talk about the downsides. Oh, and Ben says he might have a few ideas on that one. Go for it, Ben.
Okay, this is Beverly. I'm going to go ahead because this is my privilege and honor to introduce Ben Court, whose passion for prevention, harm reduction, and recovery comes from his own lived experience. Ben has been in recovery since 1996 and has a personal motivation to see the harmful effects of substance misuse and abuse be minimized. Ben is the CEO of Foundry Steamboat Springs, an inpatient treatment facility for men in Colorado. Ben is a junior fellow at the University of Florida within their Drug Policy Institute, a board member of NALGAP, National Association of Lesbian, Gay, Bisexual, and Transgender Treatment Providers and their allies, a board member of SAM, Smart Approaches to Marijuana, and faculty within numerous other institutions. Ben is the author of Weed Incorporated, The Truth About the Pot Lobby, THC, and the Commercial Marijuana Industry, and has many educational recordings, including TED Talks. His leadership for prevention and addiction treatment is extensive, including work with various hospitals, nonprofits, state governments, professional and collegiate athletes, labor industry, and private entities. Thank you for being with us, Ben. I pass it to you.
Thanks, Beverly, and Libby, thank you. It's always such a pleasure to be with you. And it's funny, we live so close to each other and see each other all over the country on these things more than anything. There is not a presentation of yours that I watch that I don't learn something, Libby. Thank you very, very much. I feel a little bit bad for what Representative Heiner just said. It was the best presentation he's ever seen on cannabis, and here I'm going to go and blow the whole thing. I will do my best not to screw up everything that Libby just said. So I'm going to try and share my screen. Let's see if this works. Can you guys? Well, dang it! I don't think I have it up.
You should be able to, Ben. Yep, you should be able to go.
Yeah, totally. Sorry, everybody. I'm kind of having a bit of trouble with this.
Better get your assistant, man.
Damn it, Raymond. Okay, how's that?
Great.
Can you guys see it okay? Beverly, can you see that?
Yes.
We can. Yep, it's perfect. Thank you.
Okay, great. All right, so I will do 45 minutes or so on, there's a little bit of overlap between what Libby and I are talking about, but not a ton. And then there's some great questions, it sounds like. For what it's worth, for you lawmakers there. Ever since, maybe 2014, I've been spending a pretty significant amount of time in your state, not just hunting and fishing, in addition to hunting and fishing, educating on this subject. And I've actually worked for the state of Montana, New York, West Virginia, and then 2 countries, helping them put together legislation that actually makes sense. Because the problem that we end up with most of the time is the laws are drawn up by lobbyists for that industry. And if we aren't pretty hip to what's going on, it gets super easy to allow some loopholes that can lead to some really gigantic issues to sneak through. So let me do my best to share with you what I've got. And greetings to all of you, our lovely neighbors from the north, from your neighbors to the south. Kevin, thank you for that picture. I hope that was one of the 2 you expected. We are well aware down here that we are basically your Mexico, that we are your main supplier of drugs. And well, sorry about that, everybody. We're kind of doing what we can, but one of the big problems that we've got in this whole issue is, the borders. I mean, it's pretty darn simple to purchase something down here, run it up there, and triple your money. So greetings from us, and also apologies, everybody. We already did the bio, so we'll skip that whole thing. I want to challenge you for the next couple of minutes in the same way that Libby began her presentation. I've got to challenge you to consider the changes that have taken place. And we really, really have to do our best to recognize that this is the new school cannabis. It's not what you smoked in the 70s. I love that line. And I love this advertisement because I feel like they were being pretty honest about it. We are having a conversation. We're having a national and state level conversation about a plant that humankind has interacted with for millennium. We're having this conversation about like a green organic material that grows out of the ground and really has always traditionally had some fairly minimal downsides to it. However, the conversation versus the reality are really, really different, because we're not talking about the cannabis of the 60s, 70s, 80s. I got sober in 1996, June 15th of 1996. We're not even talking about the weed that I knew back in the 90s. So I'm gonna change my vernacular a little bit, and I would encourage you to consider doing the same. I'm actually writing another book right now, which I swore I would never do again because it's such a pain in the butt. I like reading. I'm not very good at writing, but it was time to put another one out there. And the first chapter, Libby, I actually need to send it to you and see what you think of this first chapter, because the whole thing is me kind of imploring the reader to stop using such a generic term. Stop using a term like cannabis or marijuana, because I say it's about the equivalent of saying liquid. You know, the doctor saying, okay, take 2 spoonfuls of liquid and call me in the morning. This liquid goes really good with your cereal, this one with your milk, or with your steak. There are so many different kinds of liquid out there. To say anything like that would be confusing, in the same way that there are so many different components of the cannabis plant. There are, however, 2 of them that absolutely matter the most. There's CBD, which is where you're going to find the medicinal values. And as Dr. Stout said, there absolutely are inarguably medicinal value to them. Thank God for Epidiolex, Sativex, Marinol, and Dronabinol. We've already captured those uses. We have them in a safe and predictable way to consume. The other chemical that really matters inside of the plant is THC. And if you're not familiar, which I doubt, I think we all are at this point, but if you're not familiar, THC is the part of the plant that gets you high. I mean, all capitals. No THC, no high. You got no THC, you've got hemp. You've got a pretty interesting cash crop, something that has gone to make textiles for a long time, literally makes my favorite pair of shoes, but something that I still can't support the commercialization of because my friends in law enforcement tell me what a pain in the butt it is because it looks just like a cousin of its who makes a whole lot of trouble. But no THC, no high. More THC, more high. So the market that has been created, first here in Colorado and now all over the country, is a market built on the sale of THC, not of cannabis, not of weed, certainly not of CBD. It's of THC, the part of the plant that gets you high. And actually, we've got those data. We do have limited data on a lot of stuff, but the Colorado Department, the Colorado Marijuana Enforcement Division has given us some decent data, and we know a couple of things. As Dr. Stout showed you in a different slide, I'll highlight it first by showing you this one. This is an impeccable data from University of Mississippi that we believe we'll see a continuation of in the third quarter of this year. But what you see at the beginning here is if any of you guys have ever heard, if you've had a nephew or a daughter or whatever tell you it's natural, it's natural, it's natural. Well, of course it is. It's absolutely natural. It has grown naturally in warm and usually humid places since the dawn of time. But what is natural inside of cannabis, and we actually know this going back about 1,000 years because we have found mummified examples of cannabis inside of tombs in Asia and Africa. And we're able to test it using mass spec, which is crazy when you think about it, like the role that cannabis has always played in our society. There was some emperor 5,000 years ago who was like, throw some of that shit in there with me. It's always been a pretty important part of culture. But what naturally occurs inside of cannabis is somewhere between a 0.2 and a 0.5% THC. And at those levels, the instances of problem that were traditionally seen with it were extremely minimal. And you could probably make a pretty good argument that it was really just throwing gas on a fire that was already there, a fire that was already burning, some mental health issues. And as you can see over the decades, beginning in 1960, ending in 2011, it's gotten stronger. And it's simple why it's gotten stronger, because in this country, we supersize our Big Macs. In this country, if one is good, two are better. We really like to get high around here. And if that's news to you, grab one of your brothers and sisters in law enforcement in your local community and ask them about how much we like to get high and drunk. Because if we didn't like to get high and drunk so much in this country, we probably would have about 1/10 of all of the cops that we have out there. Kevin, I'm sure you would make the cut though. So as I switch this slide, I'd like you to note this, that I'm showing you in increments of 2.5 over 50 years. When we add Colorado in with the blue line, and unfortunately we stopped collecting those data in 2015, you really start to get a feel for how significantly this has changed. And the thing that I like to tell people is that we still are continuing to have a conversation basically around this plant, when in reality, what is being consumed is this drug. And it's tough sometimes because, you want to ask people why they're not listening to those of us who are on the front line, like the addiction psychiatrist who treats people every day for this. Why are we not just taking Libby at face value? I run a treatment program in the mountains up in Steamboat, small program only for men. We actually end up treating a bunch of people out of Wyoming because it's a men's only program, and we kind of like the hard folks. We like the ones who first treatment episode don't really know what they're into, and we like the tough guys. And what we have seen over the last couple of years as the potency has gone from something fairly normal to something that's this insane is a cannabis use disorder at the levels that nobody ever has before, and associated mental health issues with this extreme THC consumption that we have never seen before. And it's really scary and it's tough to deal with. And I'm going to tell you the exact why behind it. Skipping over the rest of it for time's sake, if you'll just go down to that bottom little thing I've got in parentheses down there, the 2020 data showed us that in Colorado, 6.1% of the users purchased almost 76% of all of the THC products. And to give you a frame of reference, that year, the total sales were $2.1 billion that we're looking at there. So we're not talking about little mom and pop shops by any stretch of the imagination. Those came and went. And one of the smart things that Montana did was they started to give some real consideration to how to avoid these big multi-state and now multinational corporations coming in and taking over things. But in Colorado, that's just, we can't do it. In fact, about 80% of the dispensaries in the state are owned by 16 people, 16 organizations. This is a really, really big money industry. And because of that, they know exactly how to target market and they know exactly how to maximize their income. And the reality is that they need that 6.1% of users because it makes up 3/4 of their profit. So they have to continue to cultivate and grow that and try to have those people purchase more and then add to that group. Now, who are those people? And this is the one that strikes really close to home for me because of my own personal use as well as the work that I do. These are people who in almost every instance would meet the diagnostic criteria for a severe substance use disorder to cannabis. So I'm going to open a water. Contrary to popular belief, doctors like Libby don't just kind of walk around and look at people and say, oh yeah, drug addict, not drug addict. Take a look at their playlist, see what they drove in. Oh, you came here in an El Camino? Absolutely drug addict. Look at all that Led Zeppelin on your playlist, drug addict. They can't do that. What they have to do is use objective diagnostic criteria. And the objective diagnostic criteria that they use are in front of you. If one meets 2 or 3, they have a mild substance use disorder, 4 or 5 moderate, 6 and above severe. And the 6.1% of the people who are using 3/4 of the THC in Colorado in almost every instance are meeting the diagnostic criteria for severe substance use disorder, i.e. addiction. I'm asked regularly, one of the first questions that I usually get asked, I do some media sometimes and stuff like that is Ben, do you really believe that marijuana is addictive? And I like to answer that. I use this same quote everywhere. I'm sure you can find it out there. And people who don't know the geography, sometimes I have to explain it, but I say, yes, I believe marijuana is addictive in the same way that I believe Wyoming lies directly north of Colorado. There simply isn't a discussion or an argument around that. The only people who will argue that, just like the cigarette manufacturers did in the early 90s, are the people selling and making money off of it. Another really interesting thing happened a couple of years ago, 2016, I believe. The DSM, so this is the manual that the mental health professionals and the doctors use to determine what somebody has. This is where all the criteria is. And in 2016, first time ever, they listed cannabis withdrawal as a diagnosable condition. And I think at the beginning of this, there were folks who were kind of like, ooh, cannabis withdrawal. Well, at least it's not heroin. At least it's not meth. What is cannabis withdrawal? Like, do you suddenly realize that Yanni's music is actually terrible and you're eating way less Doritos? Like, is that cannabis withdrawal? And I wish people could spend a day doing what we do, because cannabis withdrawal is a lot more serious than that. On the global scale, it's actually, it's considered markedly ill. And one of the most insidious things about cannabis withdrawal we see is it tends to peak around, you got a peak at about day 4 because of the fat soluble nature, we think. And then you have another peak at about day 11. And usually around the day 11, 10, 12, 13, 14, whatever, is when somebody's buy-in to treatment is at its lowest. They came in really excited, they're going to do everything that it takes. And then, 10 days into it, they've decided we're liars and cheats and stealers and we just want their money. And, they're not listening to anything. And then if they hang in another week, the magic starts to happen. But one of the rough things about cannabis withdrawal is most people don't expect it, and therefore can't treat it, are not prepared to treat this. And that's pretty scary. So last year, a pain management physician here in Colorado named Ken Finn put together a medical manual that I guess is now required learning for all of the folks in med school in this country, called Cannabis in Medicine: An Evidence-Based Approach. And multiple chapters, like how it interacts with sort of every single subspecialty of medicine. And I actually got to co-author the chapter on treatment and recovery, which was super cool to have in there. And we learned a lot in researching this. So if there are any of you out there who are on my side of things, on the treatment and recovery side, and hopefully this will help those of you in prevention, here in a nutshell, the 30,000 foot or some of the things that we learned from that is that THC and addiction is very, very real, and it's not at all easy to treat. I can give a whole 2-hour talk on the idiosyncrasies of treating the THC dependent patient versus all of the other ones. It is different. We also find that it's requiring longer than normal stays in treatment, as well as antipsychotic medications. And so what happens a lot of the time is, so in a treatment environment, we can't really decide what somebody's long-term stability is going to look like until we've got past the acute stages of their use. And different drugs last for different amounts of time, but usually, a week or so, and you've got the drug out of the person's system, and you can say, okay, here's what we're dealing with, and here's how we're going to medicate for it, and here's how we're going to teach around that. And the trick with THC is sometimes it's taken as long as 3 or 4 weeks with the young men who we're treating to have it out of their system, which means that we can't really find a good psychiatric baseline until then. So our psychiatrist, a lot of the times, is just prescribing short-term antipsychotics for those first several weeks until we get to a place where she can say, oh, okay, I think I got a clear picture of that person's brain. Here's what we're going to do to treat them. And another really interesting thing that's happened in the last couple of years, last 2 years, year and a half, there's a big giant study that came out in 2012, giant meta study, that showed us about 10% of everybody who interacted with THC would develop an addiction to it at some point. And I always kind of laughed at that number because I thought it was pretty meaningless. Like 10% of the nation's population is genetically predisposed to addiction anyway. Like if you put all of us in this phone call on a desert island, tomorrow there would be, 10% of you who are trying to do weird stuff with like coconut leaves with me to spike our dopamine, because that's just sort of how we're born. That same study was followed up on and published in 2012, and the N actually got bigger. And what that showed us was that we've gone from 10% addiction rates to 30% addiction rates. And the authors were very clear in it. Potency is to blame for this. So again, I hope that that's another thing that shows you the incredible importance of not talking about the cannabis of the 60s, 70s, 80s, 90s, 2000s, but talking about the THC specific products that are being sold today. And what we're finding, as was explained to us a moment ago, many of these patients are requiring physical detox and real medical intervention to get well. Treating THC dependency is tough, and we love doing it, but not a lot of people know and understand how. And in fact, the majority of my time and the speaking that I'm able to squeeze into my schedule that I've been doing the last year has been trying to help other providers learn how to adequately treat them. So the 3 things that you need to remember and keep in mind, especially as you're considering some of the legislation that's before you. And again, to all you lawmakers out there, I'll put my number on. Feel free to call anytime. And I really am. I mean, I'm not joking. I'm up there all the time. I'll be in Lusk next week doing a presentation to some high schools and then a training for the local PD. Feel free to call anytime. And I think I'll be in Gillette in April. I also got to pick up a great muley deer mount that I have in Gillette. Kevin, wait till I send you a picture of that. What you see in these laws a lot of the time are lip service giving to protecting these things, but no real practical application. If you want to create a problemed user, if your desire is to create a problemed user who also is absolutely the best and most reliable company that the industry can have. These are the factors you've got: age of onset, frequency of use, and THC potency. So age of onset, kind of simple. The further you are from frontal lobe myelination, as Dr. Stout told us, mid-20s, the further you are from that, the worse. Frequency of use is simple as well. The further you are from zero, the worse it is. We certainly start to get concerned anytime we see more than once or twice a week. Is when that concerns me. And then potency, again, as was so eloquently described to us before, anytime we see double-digit potency consumption, which it's all double-digit potency consumption, anytime we see that, certainly get nervous and pay attention. So the last section that I'm going to share with you is a little bit about consumption trends, and then we'll do our best to answer your questions. Those of you who've ever seen me talk before, you know how important this one is to me, because I think it's there's a real learning opportunity in seeing this. So if you're not familiar with what concentrates are by the market, concentrates are more valuable than, we sell more concentrates in the state of Colorado than we do the flower. So just remember that when people say weed, at least down here, this is what they're talking about. We call it crack weed, affectionately, because this is what it looks like. And again, my friends in law enforcement and those of you in prevention, I think a lot of the times I'll show them this and they'll say, well, that's not weed. And I say, yeah, no, like I totally agree with you. But according to the law, which in Colorado, marijuana is defined as, and I quote, every salt, derivative, extract of, or concentrate from the cannabis plant. This absolutely is weed. So what you're looking at on the left is the 2018 Cannabis Cup winner, which is like, you know, the big award ceremony that we do for who makes the best dope. And then there's the 2019 third place. Sorry, I didn't get a picture of the first place. And then here is the 2020 first place. And again, I hope some of you are looking at that and being like, good God, that's meth. That's crack. Yeah, totally. This is a clear rock form of concentrated THC. This is what it looks like before it cools. If you can consider the amount of scientific acumen it takes to go from a green, leafy, organic material to this, you'll start to see some of the size and some of the power that this industry has. And as Libby showed us before, yes, some of these go up to 99% pure THC. And the scary thing about these concentrates with the 99% pure THC really is that when I say our, I mean humankind's knowledge of what's taking place above 15, 16% THC is, I mean, to say nascent is generous. It's almost non-existent because these studies take time and we just haven't gotten there yet. So when you ask the scientific world to explain what happens to the human brain and body when they put this substance in, a 99.9% pure THC, their answer, responsible answer, has to be, I don't know. When you ask those of us who aren't a part of that world and just kind of do what we do, we say, well, it's absolutely freaking terrible. It's psychosis, it's addiction, it's stuff that you can't really imagine. There was a crazy publication last week about an instance of psychosis and self-harm about these things. I'll save that for later. But what this is doing to the human brain and body, anecdotally, is really scary. And back to the question that was asked earlier, how do you in Wyoming keep this from coming up? Again, I apologize, you cannot. We are bringing it up all the time because there's a huge value in it. However, it will get markedly more difficult for your law enforcement if someone is allowed to possess in Wyoming. Right now, what you've got is any weed, look, you're in trouble. Any form of THC, you're in trouble, and we're taking all of that. If you start allowing medical, then it's just going to get easier and easier for this stuff to happen. So let me show you, and this is actually really interesting stuff. Let me show you a quick video about this. Is a sample, somebody sampling a concentrate at a dispensary in California. I like this because this is a pretty big dude. And it's a loud video, so I'm not going to show the whole thing. This isn't weird freak stuff with concentrates. This is what happens with concentrate consumption until someone builds up a tolerance, which can happen pretty quickly. And it's really weird stuff, actually. And again, this is just to show you how much we don't know. Traditionally, cannabis, everybody's heard this whole glaucoma thing, take it for glaucoma because it lowers interocular pressure. Go to the American Glaucoma's website and see their statement on it. But it does lower your blood pressure. Traditionally, cannabis has always been a vasodilator. It's something that slows you down. However, and for whatever reason, which maybe, Libby, you've seen science that I haven't in the last couple of months, because we don't really know why, these concentrates are acting as a vasoconstrictor. So the exact opposite. They're spiking heart rates about 50 beats per minute out to 3 hours. They are spiking blood pressure and respiratory rates. So you spike blood pressure, you spike heart rate, you get fainting. I mean, kind of some 101 stuff there. And this is what happens. I'm not going to show this video because I'm going to run out of time, but can I encourage all of you, please, pretty please, to go to this dude's website. If you want to learn some crazy stuff tonight, here, I'll show it to you in a second. It's called Stoners Are Weed. And he's got several channels, but the one I would encourage you to watch is the one called Kill a Friend Day. And Kill a Friend Day is where he gives dedicated marijuana consumers their first concentrate hit and then films, for him, the hijinks. For the rest of us, the psychosis that follows. So I'm going to skip that, especially to you lawmakers right now. When considering how to build regulation around this, do not be fooled by the people who are telling you that it's akin to building traffic laws for something from the 30s, something that can go 40 miles an hour with a tailwind downhill. You have to build regulations and assume that what's being used is what's being used everywhere else in the country, which is an equivalent to that Bugatti. They aren't smoking 2, 3, 4% reefer from the 70s. They are dabbing 70, 80, 90, 100% concentrates. And so when you create the regulatory infrastructure, you must keep that in mind, because if medicinal comes, it's got to be held into a seriously regulated market. And again, call me up. I'm more than happy to share some stuff I've seen work and not work there. So let's just very very quickly, I want to show you what cannabis in Colorado is. And if you look at the far left, we see, it's things like that bud. No, it's not the bud anymore. It's butter, it's wax, it's shatter. Cannabis of the 21st century looks like this. And look at the language that they're using. That's cannabis. It's not cannabis. Cannabis is a name of a plant. That's an extract of. This is something called live resin. This is something called shatter. Here's a different form of live resin. This is interesting. It's actually in a powder form, so you can inhale this that way, put it on things as well. There we have preloaded syringes with THC in them. That's a sheet of shatter, something like that's going to be 85% THC probably. This is something called honey. Different forms of shatter. Again, listen, if you're out there and you're trying to be hip, stop saying 420 because that's not cool anymore. Like 420, you sound old. Say 710. 710 is oil spelled upside down. July 10th is like the new day for that. And oh gosh, I'm afraid. Hey, what time did I start? I got to wrap it up, don't I? Yes.
You got a few minutes, Ben. You're okay.
Okay, I want to make sure we get questions, especially since you got Libby. Here's vaping. Here's everything you need to know about vaping in a nutshell. Listen, everything that people are vaping, if it's THC, is a form of concentrate. Write that down. Remember that. I can say that with absolute certainty that anytime somebody is vaping THC, it is a form of concentrate. And the reason why the users like it so much and law enforcement and school administrators hate it so much is because there's no smoke, no smell, no mess. This stuff also is clearly and intentionally marketed to and targeted at children. Look at that ad. Amazing fun flavors, no cannabis smell. We have vaporizers in the form of cups. That is a functional pen where I could actually sign my speeding ticket with that pen and then turn around and vape concentrated THC. There is a THC smartwatch, THC vaping smart pack. That lipstick is a THC vaporizer. The marker, the hoodies, everything, the smartphone case. Be very, very aware that they have built THC vaporizers to blend into everything on earth, asthma inhalers, lighters, etc. And there I'm going to end you with the classic bubble gum flavor, THC. Adult use, my ass. This is specifically targeting children because they're a better market and they pay more. So edibles, here's what you got to know about this. Can't do it. Hey, cops, check out that last one. Super easily concealed and transported. This is why we should probably test just about everything. So 10 milligrams is the legal dose. The problem that we have is that like in that pack of gummies I just showed you, we're putting 100 legal doses into one piece of candy. So one of the things you've obviously got to do is say one wrapper equals one dose. And the real scary thing, do you remember just a minute ago, I showed you the slide of the clear liquid. Remember that one? That's a form of concentrate called a distillate. And what we've been doing the last couple of years is we've been infusing our edibles with a distillate. So this is that 99.9% pure THC. So this particular edible, this little gummy has 10 legal servings at 100% THC because it's a distillate. So this is really, really problematic. And again, I'm not going to get into it, but this is where people end up in the hospital from this. And then if you don't do a good job of regulating the amount you can put in it, you end up with stuff like this, 1,000 milligrams, so 100 legal servings. There is a cake pop, like at Starbucks, there's a cake pop with 1,000 milligrams in it. So the wrapper on that cake pop says cut into 1/100ths prior to consumption. It's laughable when you think about it, but hey, shame on us for letting them get away with it. So here's where I will end with this giant statement, then I'll show you some fun pictures. If it can be introduced into the human body, it is being commercially produced with THC in it in Wyoming's Mexico. And you still haven't militarized our border. Thank you for not doing that. So that means it's all up there in Wyoming. Anything that can be introduced to the human body is being commercially produced with THC in it. So again, law enforcement and school folks, get ready because THC comes in ketchup, hot sauce, barbecue sauce, mustard. THC comes in coffee and K-cup style coffee. THC comes in lemonade. It comes in hard candies, granola bars, ice cream, THC infused nasal mist. Of course, you won't smell that or anything there. Just spray it right up your nose. That is a topical intoxicating THC. So this goes through all 3 layers of your skin into your bloodstream to get you high. Here's a THC pill. That's a THC lollipop with 7 legal servings, by the way. We have THC chips, Weedos. That's not a joke. That's a real thing. We have THC infused potato chips. We have THC infused tampons. And if you'll recall the fad that went around for a while with the alcohol infused tampons, I mean, it's an incredibly efficient way to deliver a substance into a system. And it's trouble. This to me, and Libby, I'm not sure if you've seen this yet, these are pretty new. This is a water soluble THC drop so that anything you have in the world can be turned into an edible. You could pull this out, drop a thing on your broccoli at dinner, boom, you've got THC infused broccoli. So this one's causing a whole lot of issues and also making searches inside of treatment a giant pain in the butt. We have THC gum, there's no smell with it, THC tea. So I think you're getting the point. Gummies, candies that are made to look exactly like other candies, pot rocks, that's not a joke. That's a popping THC infused candy, not for grown-ups. Sweet tarts, THC infused alcohol, THC infused soda, which is fun, by the way. This has 350 milligrams, this Keef Cola. So the instructions on it say that you're only supposed to fill up the cap and drink that. Put Keef Cola into YouTube and watch all of the children not filling up the cap because it's all kids who drink that. If you keep up with rap culture, here's your THC infused syrup, THC infused punches. Oh God, this is like the apex, I think. I feel like we finally have hit the top of it. We have THC infused water. I mean, like there, anybody could be consuming anything around you, chai tea and juice and mints, blah, 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 blah. I think you get it. THC liquid. Oh, there's a THC deodorant made to get you high. Here's a THC infused breath spray. I thought that was pretty awesome. Here's THC infused lube. Here is a THC infused suppository that I actually bought for a documentary that was filmed in Colorado not too long ago. And I think I'm going to leave it at that. Skip these last couple of slides. We'll go to, I have to end it with this for you, especially for, there's a book if anybody wants to read it, but it should be a new one before way too long. Especially to my friends in law enforcement out there. Wyoming, I ask you, why blaze it when you can glaze it? Because we all know that these crime fighting power pills are what the men and women of law enforcement live and die by. So let's keep with the glaze and ease up on the blaze. Kevin, did you see that one coming?
I figured both of them.
Thank you, Ben. Thank you, Livy. Tana, are there any questions in the chat that need to be read out?
My apologies. Sarah Murdoch asked, if we already have medical marijuana available, why do we have to pass bills to get medical marijuana? And of course, Ben said, good question. And I think Ben and Libby maybe did a really good job of explaining. But Sarah, do you have any more questions, or would you like to question that further?
I don't want to sound, disrespectful or anything, but it seems so obvious that this is such a bad idea. Why do legislators even entertain the notion of legalizing marijuana when there's all this information out there about how bad it is for their populations? Is it truly all about the income? And if so, how, I don't know how they can make income the most important consideration when there's clearly so much fallout from this. I just don't understand.
Sarah, how familiar are you with the higher art form of the Wu-Tang Clan?
have no idea what that is.
It's a rap band out of New York that has a song called Cream, and which is cash rules everything around me. And if this were a country where logic ruled the day, but it doesn't. Political donations and greased skids, and cash rules everything, Sarah.
It's so disgusting to me.
And you
I
can
don't think
36 Chambers, which is a great Wu-Tang album, and just check it out.
Yeah, I don't think that you're disrespectful at all. I'm putting it that way. You know, there are several bills nationally. Chuck Schumer has a bill where he wants to legalize marijuana nationally. And the only good thing I see out of that is it would totally eliminate medical marijuana, in the fact that in his bill, it puts the FDA in charge of medical, which means it would have to be just the things we have and anything else that got studied in the way FDA studies things. So it would just be the separate cannabinoids that would be, quote, medical. But I don't think that bill is even going to go anywhere, because I think that they're leaving it up to states, because, you know, this is a states' right issue and states can decide that. And, you know, I would commend anyone that would try to fight this. But it's just, it seems like the momentum is there because people want adult use. And they couch it as medicine, which is totally wrong. And so, you know, I would love to see a state that actually stood up to that and say, we're not having medical, we're just having recreational, because that's all it is. And there are people in the industry that are fighting that too, because that is their claim to fame, that this is medicine. And that's why they can push it, because it is medicine. But as Ben just showed, it isn't medicine. All that stuff. I love seeing what Ben has, because God, I see something new every single time.
So Sarah, this is Albert. You know, obviously you and I have talked. As my constituent, I guarantee you I'm not going to vote for it. But what can happen, I'm not going to vote for legalization, medical or recreational. But what can happen is the people can speak, right? And I mean, that's what's occurring in Wyoming now. Will that ballot initiative, or will that petition, that ballot initiative get traction? And ultimately, will the people vote, whether they're informed or not? We don't have to be informed to be voters. We all vote on things lots of times that we're not informed on. So they can vote it in, and then the legislatures can be stuck with trying to develop the specifics of the law, depending upon how tight the resolution that passes the state is. So that's one reason. And I'll give you other reasons, not me, but I'll give you other reasons legislators consider this. There is a very strong libertarian backbone in many legislators in Wyoming. And that means libertarian on all accounts. It doesn't matter probably what drug it is, but certainly the perception of the old marijuana, right? Not the new marijuana. And so that's one fact. And then there are legislators that have seen, I think, that support decriminalization more so maybe than legalization. And so that gets all mixed into it, right? They've had children or grandchildren that have been caught up in and become felons, for, you know, in many cases where they don't feel that was right. So you end up with a whole bunch of different things happening that can cause, I think, support for legalization or decriminalization. I'm just not one of them. I'm an old school guy. I have not been convinced. But what I did ask, and I continue to ask Tricia, and she's going to give me that list. If a bill comes and it's going to pass, I'm not going to vote for it, but how do I amend it to cause the least harm to people in the state of Wyoming?
Yeah.
And the other question, it'll go to my sheriff, and I see his placard on the screen is, how do you make a law that ultimately is enforceable by police officers? And what is the cost of that? What is the cost of that? Who bears that cost to enforce that law? And so, to me, there's too many questions, but we're all individuals in this. And if you look on the list of legislators here, there's not many, right? There's 90 legislators, and I maybe have counted at any one time, I don't know, maybe four or five on this, and they're not all hearing what Libby and Ben have told us. And so I think it's continued education, but ultimately the people will decide this. It's not legislators you all got to convince. It is the general public that has to have an understanding of this, because we are as legislators, we are the arm of our constituents. And so that needs to be reached out to a much broader audience, I would say. So I really do appreciate it. And Sarah, just know that while I'm in here, I won't vote for it.
Well said, sir.
Thank you, Representative Summers. Millie Friday says, so we need to be proactive and prepare a bill? That's a question.
There
And-
have been those who've done that. And it's certainly doable. Colorado tried to fix it ex post facto with our own bill this year that Libby mentioned. Certainly, it's possible. And if you do, I mean it, feel free to give me a buzz, and I'll tell you what I've seen work and not work.
Yeah, right now, South Dakota is working on a bill that is legislation, and they're trying to put a limit on potency. That's that. I mean, it really does help if you can get stuff in there that you would like to see, like strict, really strict regulations, like that graph that I showed. It has to be really strict regulations for this to be successful and not be harmful.
And I know that we follow money. This is Albert, and I apologize for speaking again, but I kind of talk about it. But it's not always the case. If you look, I think South Dakota, Montana, those were all ballot initiatives from the public. And Utah, I believe, had one, and they're trying to figure out how to navigate language that was in a ballot initiative. And so I think the people pushing those initiatives are all about money, right? The voter is simply reacting to the material that is being pushed at you. And you all don't have enough money in the game to counter that information out to the general public, where people are going door to door, right? This is a petition. People are going door to door. You all are not going door to door.
I agree with you. And I have said in the past that if you gave me enough money, I think I could probably convince enough of this country to get a national law enacted that we should sacrifice a puppy every Sunday afternoon. With enough money, you can buy truth. With enough money, anybody can end up in office. With enough money, anything can pass. And the amount of money behind these efforts is pretty remarkable. I mean, you guys are the politicians on here know, not everybody does though, that those folks bugging you at the supermarket for signatures aren't out there just volunteering. They're all paid per signature. And if you got enough money, you can pay enough people to go out there and gather signatures forever.
True. Robert Galbraith, you had a question? Do you?
I guess just generally, who are some of these companies that are behind these initiatives? And in Colorado, I mean, this looks pretty sophisticated, all the advertising and everything. And you said they were multinationals. Are we talking like some of the big tobacco firms, companies like that?
Actually, yeah. Altria and Philip Morris have gotten pretty significantly leveraged in this very recently. Interestingly, and can't make this stuff up, the gentleman who runs the world's second largest cannabis company right now was the former CEO at Purdue Pharma. The folks who brought us the OxyContin crisis. So the very best resource I can give you for that, because they have followed all of the money on the SAM website, which is learnaboutsam.org. They have all of the big monies and the big players. Monsanto is in on this. Nestle is in on this. Scott's is in on this. I mean, you're talking big players, man.
Thank you.
So, thank you, Robert. Kevin Riemann says to everyone, legalization is commercialization, and Ben says, that's right. I would like everybody to know, and Rachel put it in the chat box, Representative Rachel Williams says she will continue to fight legalization and work to educate her community. And thanks, Dr. Libby and Ben, for being a part of this today.
Tana, I believe that Mike Yin had a question or a
All
comment.
right. Also, I would like to say that Senator Salazar from Fremont County here also wants everyone to know that he will continue to fight legalization. Okay, and Trish, who was it that?
Mike.
I did see
Mike
one
Yin.
question, a question from Mike Yin, Tana.
Wonderful, Mike. Go
Hi,
ahead.
Donna. I mean, thanks to the folks who invited me. I apologize for jumping in late. I think I disagree with Representative Summers, and my name has been on co-sponsor lists for bills, and I know at least one request has been made for me to co-sponsor a decriminalization bill. So I guess the question I would pose, I don't think full legalization is likely in Wyoming. I frankly don't think that it has the votes in either chamber. I'll be upfront with that. But what does full prohibition work, right? So is decriminalization a better path to not punish people in a way for possession, for low-level possession? Because I try to think back at full prohibition of alcohol, which I find alcohol to be much worse than marijuana. Well, the presentation I think does make a very fair point that weed now is very different than weed a long time ago. But alcohol still causes a lot of social problems and social issues, and full prohibition was a bad idea, frankly. Is decriminalization a better option, or what is there a middle ground, or is there a correct ground where we do heavily regulate the usage of weed while we don't create new social ills by putting people in jail for low-level possession?
Oh, you're speaking to my heart, sir. So let me answer that question quick, if you don't mind. Yeah, I mean, as a recovering drug addict who works with drug addicts every day, oh my goodness, yeah. There are so many other solutions than what we've got. But the space between prohibition and commercial sales is the space between Alaska and Florida. And there are so many different things we could do now. Now, personally, I have always advocated for decriminalization of anything that's not a dealing. So dealing, I think we still need to keep in there. The trick that you get to with it, and I don't know that you or I will solve this problem in our lifetime, but the trick that you get to it is if you look at the data, one of the most, and I'm a product of this as well, so I'm a little biased. One of the most effective things that we can do as a society for interventions with drug addiction is a long-term treatment program like what drug courts offer. So drug courts are very, very effective. And frankly, the only reason why drug courts work is because it's a deferred felony sentence as opposed to a deferred misdemeanor. So that's one of the big issues I see with it. However, if I had the opportunity to flick a switch and say, nationally decrim, absolutely. Low level possession, I would go for that. I might be a little more liberal, maybe a lot more liberal than some of the other people that I know. The trick we have to figure out, though, is still maintaining opportunities for interventions. If it wasn't for law enforcement intervention in my life, I'd be dead. And the other question that you asked about the how could it be done, it absolutely could be done at a national level if any one of those politicians actually wanted to dig into it instead of just go with a soundbite. And there are two of them that I'm aware of who are particularly interested in this right now, actually looking at it responsibly and regulating from a national level. But they're being a little bit cagey. So totally, it could be done. But the question is, do we have the willpower to do it that way instead of just like, oh yeah, let's vote on this because I know that'll capture another 15% in this area.
And I don't know if you saw my presentation or not, or if you came in later, but I did send that to Trish, and so she can give that to everybody. But there is a graph there that does speak to what you're talking about. Decriminalization does definitely help the situation. The best is very strict regulation, but that's like almost impossible. I do also very much support decriminalization, but I also, from a treatment side, agree with Ben that, you know, nobody stops an addictive behavior until there are consequences, and it's consequences that drive them to get better. And if we totally get rid of all the legal consequences, then a lot of people are not going to get better until it's too late. I mean, that's kind of why I've always pushed tobacco as something that treatment programs need to address, and Ben knows about this too, because if you wait for a consequence for tobacco to stop, it's too late. You're going to die, and you've got the consequence. But that's why I think treatment programs have to do this. And so many people have gotten better and recovered completely because of their legal problem. And like Ben said, diverting them into treatment as opposed to a more serious legal charge.
But it is so tricky. And I mean, gosh, you're looking at something that I think this is sort of bottom of the hierarchy of the pyramid of needs. I think that if we were really to proactively address mental health and addiction inside of this country, we would see so many other issues just tank. But the complexity of it doesn't really lend itself well to the way that we do things in this country. You know, somebody dies tragically, we create a series of laws around that, and remembering and respecting the reality that what this nation's war on drugs did to our minority population, our inner city populations, our jail populations, you're talking about big, giant, complex issues. I hope that at some point this nation decides that they are worth addressing to the level that I feel that they should be addressed, but I just don't know if there's the political willpower for that right now, sir.
Pepper, did you have a question? You're on mute.
Thank you. I'm sorry, I've been having technical difficulties. What I'm wondering is, okay, if it was to be decriminalized, because we know the initiatives are going around and everything, if it was decriminalized, then without some sort of legislation or parameters, how would, all I see is that the mental health problems are going to grow and that there'll be a lot more people in counseling and centers, but maybe they won't be diagnosed. Maybe without toxicology reports or tests or something. So, I mean, how do you combat it? I just see money coming in one side without people going to prison and without and the taxation, and then on the other side of it, having mental health problems and family problems and social problems. So it does. Am I on the right track, or is that not?
I would say that that's what you have to build into your legislation is you build in, this is stuff I tried to get into our bill, but it didn't get in. We need the data. So people have to ask the questions. And like I work at an FQHC, so primary care for people, and I'm the psychiatrist. And everybody gets questioned about alcohol. How much do you drink? How often do you drink? What do you drink? Everybody gets asked about tobacco. How many pack years of tobacco? They ask about drugs, but they don't ask about marijuana. And most people don't see marijuana as a drug. So they need to have specifically questions on what type of marijuana, the potency, how you're using it, how often, when did you start using it? Then you also have to get drug screens. You have to do drug screens. This is not to criminalize somebody. It is to get the information, get the data. The toxicology needs to be done on all violent crimes and suicides and I think you have to mandate that the information is collected so that then you know more about it. Hospitals need to report it. We need to get ICD-9 code, ICD-10 codes that are specific for cannabis and specific for all of the different things cannabis can do, so that we can get the data. And that's what needs to be spelled out from the beginning. And so you can decriminalize small amounts of possession, and so they don't get a major charge, but you're still collecting the data to help them navigate the system and to figure out how we're going to deal with this. Rich?
Hi, thank you. I'm Rich Adrians. I'm the facilitator for the Governor's Council on Impaired Driving here in Wyoming. And so been following this issue for a long time. Just a couple comments. One, we talked about prohibition and how it didn't work. Back in the 30s, only about 30% of the population consumed alcohol. Now about 64% of our population is consuming alcohol. So whether we legalize, decriminalize, we as a society just have to be prepared for what burdens that's going to put on us. From your data that you shared today, we're looking at a substance that is far more addictive in high doses. And even if we are able to limit the percentage of THC, it'll be like managing beer and wine and liquor. And so just a tremendous, tremendous thing. As far as the ballot initiative, I would just encourage our legislators, don't jump the gun with the ballot, with any legislation myself. They only have about 30% of the signatures they need to put it on the ballot, and they're struggling to get those numbers. They've failed twice before. I don't think the constituents in Wyoming want marijuana legalization. And as far as our libertarian folks that are out there, we all live in Wyoming for a reason, and we don't like government in our business, and understand that. But understand public health dollars will be needed to treat the increase in the number of people who will be addicted based upon the presentation today. So when you're going to allocate dollars and you're beginning to think that you might get some revenue, be prepared to allocate those dollars to help treat these folks in the increase. So it can be very personal. Ben, I've heard you speak before, and Libby, I think you were in Cody maybe 8 years ago when I was chief in Sheridan. I was able to attend, and just fantastic presentations. I've recommended the legislators I know reach out to both of you for your comments. I think they're very important. Thank you for today. I appreciate it.
Thanks.
Yeah, I would just like to, kind of, before we close, there are two amazing resources here, with Ben and Dr. Stout, and reach out to them. They have a lot of experience, and it's the right kind of experience. Sadly, it's been tough experience, but they're it. So reach out to them, utilize them. So I just want to thank you all again. Thank everybody that joined us for your time, your interest, your dedication to better education. Knowledge is power, and that's how we make our decisions, right? The better informed we are. Are there any final comments or questions before we close?
Just wanted to speak up to Albert. Albert, you asked for 5 bullet points. We will get you those 5 bullet points, and we will get them out to you, and we will get Libby's presentation out to you as well. And I'm sure that Ben's as well, he can send to Beverly. So we'll get that out to you. Thank you so much for coming.
Yeah, I'll send it over, Beverly. Thank you all. They're kicking me out of where I am. I'm sorry.
Just Ben.
See you all.
Thanks,
Well,
Thank you.
everyone.
Take care, everyone.
Later, Kev.
Later, Ben.